and I have a privilege to organize this event from Vygon with the partnership of our channel partner MediWide along with PNF Care South Korea. We have a privilege of sharing knowledge from Professor Kim from Korea and Dr. Shah from Malaysia and Dr. Afifi from Malaysia. And before I take more time, and I will pass over our facilitator, Dr. Afifi, to give an introduction about our speakers. Dr. Afifi, over to you.
Hi, everyone. Thank you for joining in and listening to us. This webinar is going to be on continuous peripheral nerve block. It's a sharing session in between two countries. We have with us, I'm honored to host our respectable guest from South Korea, Professor Jin-Tae Kim. He is the professor in the Department of Anesthesiology and Pain Medicine at Seoul National University College of Medicine. He is also chief of Pediatric Division of Department of Anesthesia and Pain Medicine, and is currently member of Planning Committee of Korean Society of Anesthesiologists and Director of Academic Affairs of the Korean Society of Regional Anesthesia and Director of Planning for Korean Society of Pediatric Anesthesiologists. He is also the director of the Korean Society of Cardiothoracic and Vascular Anesthesiology. So he carries many hats. He's wearing a lot of, handling a lot of responsibilities. And our second speaker of the day is none other than Dr. Shahridan, who's currently a consultant anesthetist and regional anesthesia expert. He in a hospital, Gleneagles Medini, Johor. He was the past convener of Malaysian Special Interest Group in Regional Anesthesia. He has been trained in United Kingdom. He passed his fellowship in regional anesthesia, in anesthesia, FRCA, many years back. And he continued further after a short stint of a lectureship in HUKM. He continued to further his subspecialty in regional anesthesia at Royal Perth Hospital. And upon returning home, he started venturing into greener grass in Singapore and later on in private center in Singapore. He's doing a lot of block as well, even while doing private practice. And myself, I'm Dr. Afifi. I'm here in Hospital Sultanah Bahiyah, Alostar. I'm doing pain medicine. I'm a pain specialist as well as doing regional anesthesia on my OT days. I'm happy to start. Mr. Tana, are we good to start?
Yes, Dr. Afifi, we start with Professor Kim.
Yes, so our itinerary, we will start with Professor Kim, who will start with Dr. Shahridan, who will introduce on continuous peripheral nerve block, and Professor Kim then will take us through the whyness, the reason why we need catheter, the technicalities on inserting catheter into a peripheral nerve block site, as well as how to secure and fix a catheter on board. And if we have time, I will just jump into a brief slides on challenges that we need to face while performing peripheral nerve block. Over to you, Professor Kim. I'm honored to listen to you at the moment. Please do, Professor Kim.
So, am I starting first? Or?
Sorry. Shah, Dr. Shah, please start.
Okay. Okay. Thank you, Dr. Afifi, for the kind introduction. Assalamualaikum and a very good afternoon here in Malaysia. Okay, let me just share the screen. Okay, thank you again. So, when Vygon and the Malaysian distributor approached me, so I thought how we're going to handle this, because we have Professor Kim, who's going to be very technical with regards to his presentation. So I thought of giving more of a pep talk and kind of discuss how, at least in the hospitals I worked in, we have encouraged the uptake of regional blocks from single shot to continuous techniques. Okay, this is where I worked in. I'm working in, it's a small private hospital with multi-specialty. We have a strong RA practice. which I will allude to in a short while. As highlighted earlier by the chairperson, I was the previous convener of the special interest group in regional anesthesia under the College of Anesthesiologists. So this is where we started to build out our in terms of networking and as well as training and as well as supporting the propagation of regional anesthesia. We had this last 2 months ago. Okay, I'm not going to go into great detail, but I'd just like to borrow, I was actually chairing the session. I would like to borrow a few slides from the first speaker, Dr. Amiruddin. So basically, regional blocks, regional anesthesia is actually a business class pain management. This was actually an editorial by Bansoi in 2014 in RAPM. So, we want our patients to be as comfortable as possible, and if the option of RE is available, should we not promote its effectiveness and advantages over other pain control methods? What better reason do we need to stop doubting the merits of RE? In this editorial or letter to editor, he pointed out, with or without RA, that, for example, if you're traveling in economy class without RA and regional in business class, at the end result, with the current evidence now, maybe outcomes may be the same. But if you have traveled in business class and you can afford business class, if you are to travel again in air travel, you would most likely opt for business class because definitely it's pain-free, it's comfortable, there's less opioid needed, and less complications of opioid. This is something that this is actually a strong case why we anesthetists should actually offer regional blocks to our patients. And when you talk about continuous peripheral nerve blocks, of course, these are the benefits: superior pain control, reduced opioid consumption, prolonged time to first analgesia request, enhanced satisfaction, reduced post-op nausea, vomiting, and reduced time to discharge readiness. And interestingly enough, with regards to rebound pain, this is an article, review article in KJA last year. So you can see that if there is no PNB, of course, it's going to be intense pain, and over the time, your pain will come down. If there is a block, the blue color one, but without any multimodal analgesia, you will see this is the phenomenon of rebound pain. And when there are single shot with multimodal analgesia, there'll be a little bit of rebound pain, not as high as without multimodal analgesia, and the pain scores will go down. And when we incorporate the continuous techniques, you could see that the pain scores are definitely reduced significantly over time until we stop them. So this is something that we need to look into, how we are going to basically implement this in our practice. This is something that we know the benefits, but how are we as an institute, wherever we practice as an institution, how are we going to implement it? Because it should be in the armamentarium of most of our colleagues. This is something about change management in anesthesia. I was exposed to this change management when I was working in Singapore, where we had to do continuous clinical practice improvement program. So this is just something that Catheter wrote, which is one of the leading change management books, Leading Change. I'm not going to go into great detail, but this is some of the concepts that I thought was beneficial in at least the current hospital and my previous hospital in Singapore, in terms of how we managed to actually increase the practice of regional anesthesia from single shots up to continuous. There must be some buy-in, okay, particularly from the surgeons. If the surgeons are against regional anesthesia, it's probably you are fighting a losing battle. So this is a symposium that we conducted sometime last year, and I gave a talk on enhanced recovery strategies in breast surgery. This is how, and in the talk, I also illustrated how I got the surgeon I got buy-in from the surgeon. Because when I shifted over in 2017 from major breast surgeries in my current hospital, what the surgeon did was local infiltrate the skin and subcutaneous tissue, and the standard GA with a bit of opioid. And I noticed definitely there's significant postoperative nausea, vomiting, pain control may not be the best, and so on and so forth. And then of course this is where I kind of discussed with my surgeon, who's a brilliant guy, Andrew Gunn, who's willing to listen, and I kind of sold the idea, or why don't we try blocks and see, and also TIVA. So what happened is that for all his cases, I started doing TIVA, and we started to do blocks. This is just illustration of one of the blocks that I did. So this is the LA spread between the pec minor and the serratus around the fourth rib. So what happened was that eventually all his patients are, there's nearly zero case of postoperative nausea, vomiting. The patients are comfortable, and he now asked if I'm not doing the case for my other colleagues to actually deliver the same kind of anesthesia. And one more thing that he is interested in is the fact that he appreciates the spread of the LA in the plane, because that's where he, particularly in the case of axillary clearance, because he uses the LA spread where there's edema and so on to actually realize or stop where the plane of dissection is. So this is something interesting, because where in my previous hospital in Singapore, where the surgeons were against this because of the fact that he believes that it disrupts the plane of dissection, but in my current hospital, he appreciates it and wants it as a guide for his dissection plane. So now all our major breast surgeries will be performed with TIVA, as well as some form of PEX block. Another issue is that if you are doing this block alone, and if you're not around, it's going to be very difficult. This is where you need to establish some sort of a capacity building, a training, a certain mentorship for your other anesthetic colleagues who may not have the same skills that you have. So this is just to highlight what I did recently. This is Dr. Ng Chong King, my colleague, so I'm helping him. This is a post-thoracotomy ESP, a continuous block that we did. So just to highlight, this is the video of the catheter. You can see. Sorry about this. Can you see the catheter? It's quite okay. It's not gonna. And you can see the LA spread, and the catheter is quite in the actual plane. So this is quite good because the patient is fairly thin. So this is, and you see it's only about 2 centimeter where the ESP is located. So we have encouraged this, and to a certain degree, there's also a lot of surgical buy-in. Now we are getting referrals from our surgeons for post-operative analgesia for rib fracture traumas. Even patients who do not come for surgery, but they're admitted for chest injury with significant number of rib fractures. We get referred for actual catheters, and we had one recently where the surgeons discussed with us, whether the elastomeric pump can, the patient can be discharged home with an elastomeric pump, which eventually he was discharged with, and to be removed in the surgical clinic. So this is something interesting where the surgeons have seen the benefits of RA, and there's a lot of buy-in, and then it turned out to be more of a demand, and with that demand, you can see the uptake of regional blocks is increased. A lot of people who have not, or who are not doing it as much, are doing it a bit more. There's also, if you don't have a mentor in the current hospital, so with this day and age of telemedicine, you can actually do quite, you can actually get a mentor who oversees you, who supervises you from a distance. This is just to highlight a point. I was contacted by EPO-ED. They were doing basically single shot erector spiny plane blocks in the ED. And this is a picture of me, something here. And then we are using FaceTime. And I was shown the actual ultrasound and kind of supervised. And it was quite remarkable to see that these patients improve immediately. There's a lot of data to suggest that pain from rib fracture is it's definitely remarkably reduced with erector spinal plane block. So this is something that you can consider if you are in a place where there's no mentor around. You can use telemedicine, your video conferencing and so on to actually seek some sort of supervision. We also need appropriate equipment. Of course, you have to have the best of equipment to encourage uptake by your colleagues. So this is just an example of the block trolley that we have, but there are a few things that we need to consider. First, of course, is a good machine. This is what we have. We wish we could have something else that we should export, but this will do. So a decent machine that can do things like needle enhancement, beam steering would probably be good, particularly if you are new to this the blocks and you want to kind of improve your chances to actually seeing the needle. It's good. It's very important to have good machines that can help you to perform the blocks. Another point is that this is just a recent study, 2020, in Nature, actually, about photoacoustic needle or say echogenic needle. So this is something important when you are deciding to purchase a needle. Consider purchasing echogenic needles so that this will enhance or make it a lot easier for you to actually pick up the needle in the ultrasound. And finally, I think a game changer, that's something that we have just used in the last few months, is actually the needle guide. And this has made a lot of blocks easier. For example, the PEX and the ESP, which alignment of the needle in the ultrasound beam is always an issue. We have found that using this, even among the ones who are probably not so much doing the blocks, have found that actually doing the blocks in an in-plane approach is very much easy. So this is something that there's not much in the literature about it, but I believe it's actually a game changer for the ones who are new to the blocks. And if you want to encourage more uptake, more I would say blocks being performed by other people. So I guess if you are doing it on a regular basis, probably for most of the other basic blocks, for example, lower limb blocks, femoral, it's probably not necessary. But there are certain blocks where this will be very helpful. If I could conclude, if you want to encourage, I'll say RA practice among the anesthetists in your particular institution, there need to be buy-in from the surgeon, so that then there will be minimal resistance. And that mentoring, whether an in-house mentor or somebody from outside, you can use. We can capitalize on what they call tele-supervision or telemedicine and the appropriate equipment. I think with that, I thank you.
Thank you, Dr. Shah, for an excellent introduction on the creating market for peripheral nerve block, and he has successfully been doing it in his place of practice. Even in private hospital now, the demands for blocks are really there. So without further ado, I would like to invite Professor Kim to start his presentation on the reason why we need catheter, and secondly on the technicalities associated with insertion of a catheter. Please, the floor is yours, Dr. Professor Kim.
Thank you for a kind introduction, Dr. Ahmad. Okay, today I'm going to talk about the continuous peripheral nerve block, especially on focusing on catheter. During my talk, I will briefly go over the benefit of continuous peripheral nerve block, and I will review some problems associated with continuous peripheral nerve block and their possible solution. Lastly, I will show some demonstration of fixation of the catheter. The continuous nerve block has many good points. It can offer extended postoperative anesthesia by administering local anesthetic continuously near the nerve, and it can provide superior anesthesia with less opioid consumption. Sometimes you don't need opioid at all for pain control. Therefore, it can decrease opioid-related side effects such as nausea, vomiting, respiratory depression, constipation, and pruritus. Patients don't have to suffer from such kinds of side effects anymore. Continuous nerve block can replace the central neurological block, such as epidural block, and avoid some drawback of epidural block while maintaining a similar quality of anesthesia. Continuous peripheral nerve block has less hypertension and less urinary retention, pruritus, and mobility restriction compared with epidural block. In addition, continuous peripheral nerve block provides other clinically benefit. It can be used for rehabilitation, exercise, and for control of phantom pain. So many studies have shown that the continuous peripheral nerve block provides superior anesthesia and require less opioid consumption compared with a single injection of peripheral nerve block. And good things of the continuous peripheral nerve block that it works well with most kind of block. For example, femoral nerve, fascia iliaca, adductor canal block, and PANG, ESP, TAPS, brachial plexus block. So if you can block the nerve, then you can insert the catheter and you can take advantage of it. So it is good. And also the continuous peripheral nerve block reduce phantom limb pain as well as physical and emotional dysfunction for at least 1 month. Preemptive use of continuous peripheral nerve block in patients undergoing lower limb extremity amputation reduce the incidence of pulmonary complication and acute postoperative pain score and narcotic use in the postoperative period. And continuous peripheral nerve block is a valuable option for pain control and functional prognosis during rehabilitation. Additionally, it works very well even in pediatric patients. So I think continuous peripheral nerve block is a very good modality for us to control our patient pain during the perioperative period. So far, I have looked at the advantage of the continuous peripheral nerve block. Now, let's take a look at the problem related to continuous peripheral nerve block that regional anesthesiologists currently encounter. This study assessed the current state of the continuous peripheral nerve block in clinical practice based on survey conducted in North America. A total 232 AERSA members completed the survey. The site for continuous peripheral nerve catheter placement include all common nerve block, with many anesthesiologists still routinely placed supraclavicular, femoral, and sciatic nerve catheter. Okay, then let's review some important question and the answer. I would like you to think about your own answer to this question. The first one is, what are the most common problems you encounter while you are performing the continuous peripheral nerve block, and while you are doing the procedure, what is the main concern of yours? Many doctors seems to feel psychological burdened by time. Since the number of surgeries is quite a lot, it seems that there is a burden of delaying the case, and they seem to feel time pressure while performing the regional block. They also answered that they had some problem securing the catheter and positioning the catheter tip in the right place. And what are the most common problems you encounter after the procedure with your inside to peripheral nerve catheter? What is your answer to this question? What is your concern? They answered that they encounter problem associated with leakage, and they also have some problem in keeping the catheter in proper location. And they're also worried about the reduced block effect. Then how can we solve these problems? And another question is what type of infusion regimen with local anesthetic do you use? Based on the survey, local anesthetic delivery are mostly managed as a continuous infusion. Intermittent automated bolus regimen is not used much, but I think that it is good option in some blocks. So you can consider this type of the regimen. And then to what extent do you think peripheral nerve catheter can affect opioid epidemic by reducing the amount of opioid that can be prescribed for postoperative pain? As you expected, many physicians agree that continuous peripheral nerve block can decrease opioid consumption and affect significantly opioid endemic in a good way. And then the next question is, when you place the catheter for the continuous peripheral nerve block for postoperative pain, how do you confirm the final position of the catheter? What is your answer? And how to confirm your final catheter tip position? Many anesthesiologists in North America confirm the final position of catheter by administering bolus local anesthetics, and they sometimes use the color Doppler, and they sometimes use by using the stimulating catheter, they confirm the final tip position. So what about your clinical practice? And this one is the last question. Which do you feel the potential for improvement? And they feel there needs some improvement in the patient follow-up process, and then they need some designing improvement in designing of the peripheral nerve catheter, and also designing of the infusion pump. I think that the Vygon company do a lot regarding the designing of peripheral nerve catheter. I hope you design a more fascinating peripheral nerve catheter. To sum up, we identify several problems associated with the continuous peripheral nerve block. I believe most doctors in this virtual meeting encounter similar problem: time pressure, fixation problem, and then catheter tip position in appropriate location, leakage around the continuous peripheral nerve catheter, and some dislocation of catheter is also a big problem. And block failure may be due to dislocation and tip failure in tip positioning. I should not overlook the side effects such as the nerve injury. Some side effect, nerve injury last and decreased motor function also. We should focus on this kind of complication also. So then what is the dislocation rate and displacement rate, and what is the risk factor? Based on this volunteer study, displacement occurred 5% for the interscalene and brachial plexus block, and 55% for the femoral block. And dislocation rate is correlated with the time. The longer the catheter placement, the higher dislocation rate. So both movement and time are considerable risk factor for perineural catheter displacement. And another study shows that the deeper insertion, the less displacement of the catheter. So if there is you have the safety margin, if you insert the catheter a little more deeper, then the dislocation occurs less frequently. So in order to minimize catheter movement, it is better not to insert the needle too close to the nerve, and we need to fix it tightly in place where the joint movement is minimal. And it's a good it's good to keep in mind that catheter is likely to be displaced over time. Actually, there are several ways to fix the catheter tightly. I don't think there is just one right answer on how to fix it. Actually, there may be several ways to fix catheter properly. So the important thing is to fix well so that it does not move. You had better consider the direction and the range of the joint movement when you fix the catheter. So for successful continuous peripheral nerve block, I think it is very important to see the catheter clearly with your ultrasound. Let me show you some video screen and which image of the catheter more visible on these two ultrasound image, right or left? Which one is better for the catheter visualization? Okay, one is the catheter, which is the needle has been removed from the catheter over needle system, and this one is the silver stem catheter. Which one is better? Let me show you another screen, another video script. Okay, this one is the ductal canal block. You can identify the sartorius here and the femoral artery. And after inserting the catheter, we reposition the catheter under the ultrasound. And we usually insert the catheter and move slowly, identify the catheter tip here. You can identify the saphenous nerve here. And we reposition the catheter tip near the saphenous nerve. So for the correct tip positioning, it is very important to see the catheter tip is clearly. And if you look at, I will show you another slide. This one is the same block, a ductal canal block, and you can see the femoral artery here and the sartorius muscle. And you can see that the catheter here. Usually we insert the catheter more deeper, and then we slowly withdraw the catheter, and we inject the local anesthetic and identify where is the catheter tip, and we identify the spread of local anesthetic clearly, and we finally confirm where is my catheter tip is. So for successful continuous peripheral nerve block, and it is very important to where is your catheter tip, and then the visualization of the catheter is really matter. Now let me talk about the leakage. The catheter through the needle system, like a silver stem, may have some problem associated with leakage. To overcome this problem, someone used the topical adhesive. It is maybe helpful. And I think the correct tip positioning is also important. In some case, that catheter is placed in appropriate site or catheter is displaced more superficially, the leakage problem may occur more frequently. The catheter dislocation may be associated with a leakage problem, so tight fixation of catheter is important. And catheter over needle system is also helpful. When you use the catheter through the needle system, the space would be created by needle puncture after needle remover. Potential leakage around the needle insertion may occur. However, when you used catheter over needle system, even after withdrawal needle, the catheter skin and form the tight seal around the catheter. Therefore, theoretically, it has some benefit in terms of the leakage. But as I told you before, in terms of visualization, the catheter over needle system has some weak point. So you can weigh which one is better for your practice. From now on, I would like to show some demonstration how to fix the catheter in Seoul National University Hospital. I would like to show the Seoul National University Bundang Hospital that one of my colleagues kindly shared the slide. So I will show you some slide. Okay. We usually prepare like this. I think that aseptic procedure is very important. So you should be keep the aseptic protocol very tightly, because infection is very critical for especially inpatient arthroplasty patient. We usually use a sonolab, and we used a nerve stimulator also. We use when we placement catheter, we use the nerve stimulator and the ultrasound both. And after preparing the nerve stimulator, and we insert under the guidance of the ultrasound. Okay. When you insert the catheter, I recommend use this yellow tab, because if you use this yellow tab, I think that it's much easier to insert the catheter more easily, and it is stabilize the catheter. And I recommend use the normal saline and enlarge the potential space for better insertion of the catheter. And after inserting catheter, we usually connect this connector. This is a very important point. I recommend you should very tightly fix the catheter here. Sometimes there is a loosening here, so I recommend you tight seal that connection. And as I told you before, under the guidance of ultrasound, you position the catheter, and we use the skin adhesive for prevent of the leakage. We use a skin adhesive for the stabilize the catheter and block the leakage. And after apply the skin adhesive, and we use for the fixation of the catheter, we use the commercially available skin catheter, skin tape here. I want to show another screen. This one is from the Bundang Hospital. Dr. Hyun Jung-shin kindly shared this screen, video. And I don't want to over the block procedure. I just want to show you how to fix the catheter in our hospital. She used some tape here, and tape like this, and apply. After they use the surgery strip, and they perpendicularly apply the another strip. As I told you before, this method is not just one solution. There are many good ways. I hope you can find your best way for your institution. After apply another tape here, and lastly, they apply like this. Let me show you another fixation technique here. Actually, This one is the catheter over needle system. And they apply the commercially available device and fix like this. And then they use the tegaderm here. So actually there are many ways to how to fix the catheter. So, okay. So lastly, I want to comment some complication related with the continuous peripheral nerve block. There is no medical procedure free of complication. We should keep aseptic protocol to avoid infection. And we should carefully advance the needle under the guidance of ultrasound to avoid nerve injury. And we should check the pressure while you are injecting local anesthetics. And be careful the last and then other specific side effects. For example, while you place the catheter in the interscalene brachial plexus, you should find a way to avoid the flattening nerve pulse in patient with a high-risk patient. If you insert the catheter around the femoral nerve, you should keep in mind there is the possibility of the falling down of the patient. So I recommend you must find a way to avoid the complication associated with the continuous peripheral nerve block when you apply this kind of procedure. In summary, today we have briefly go over the benefit and possible complication of the continuous peripheral nerve blocks and some problems associated with continuous peripheral nerve block and some tips, some possibly solve those problems. I hope this talk will be helpful for your clinical practice. That's it. Thank you for your attention.
Thank you very much, Professor Kim. We will keep questions at the end. I will invite anyone with either a simple comments or an urge to ask practice differences, or this is a sharing session. We would probably want to know what Professor Kim is doing in his place, his protocols, his ways of managing the blocks, the catheter, duration of catheter, how he wean off catheter, things like that are probably those questions that you would want to have input from Professor Kim. I will briefly go on to my part of the webinar. I'll just start. This is not much of an evidence. I will go through challenges associated with advocating continuous peripheral catheter in your workplace. Some challenges. So my main content of the talk will be on the challenges for advocating catheter peripheral nerve block in our day-to-day practice. I will go through some possible reason that possibly pose challenges to our practice, the indications of block, the risk versus benefit, something related to organizational factors involving staffs, cultures, operative funding and cost, as well as support from the surgical side, and something about training and mentoring. So indications from my point of view, I'll briefly divide into four main indications. One is acute post-operative, post-traumatic pain, where you would want to see those involved in major surgery, arthroplasty, or those who would want to have increased perfusion in the limbs post-transplantation, for example. Those are acute post-operative or post-traumatic indication for blocks, where you any conditions that would benefit from longer duration of peripheral block. That is when we would want them on something longer. Persistent or chronic pain, as in a neuropathic pain condition, phantom pain. There are many publications and case reports for this, as well as ischemic pain. And for the reason of rehabilitation, where we have those post-adhesion release, post-contracture release, and those who need rehabilitation on specific site. For example, there are publications on the need for catheter along median nerve for exercise of the hand. And in my place, I also have been using catheter for temporary bridging therapy while waiting for intrathecal drug delivery system. I use catheter to deliver neurolysis, as in alcohol neurolysis for nerve or lumbar or plexus, and I use that for sympathectomy as well. So these are some of the patients who have benefit from catheter treatment, catheter home-based treatment. The first two photos, the left one are still currently receiving treatment at home. You can see him carrying the pump over the neck, and the other gentleman has passed on. They both benefit for many months of treatment involving home-based infusion of medication. And if you want to have home-based ambulatory treatment, you would have to have a dedicated team who can manage all sorts of complications involved in long-term management of pump at home. And in terms of putting in blocks for while bridging for intrathecal catheter, for example, if they have a site-specific regional pain, I would put a catheter to a plexus of nerve, and before putting in catheter, you would have to have some guidance on where to put it, the length, and all associated structures, so that you can manage on the appropriate good location, so that your catheter can possibly last longer, to avoid like Professor Kim said, to avoid the area where there are a lot of movement, especially around joints, and try to tunnel longer subcutaneously before getting to the area where you would want the tip to be located. And for example, another example of rescue postoperative catheter nerve block, in postoperative patient, a simple arthroscopy where you would think a single short block would be helpful, but they may need catheter in the long run. And this patient especially was crying postoperatively during one of our round, and we offered catheter for just a couple of days. And post-contracture release is another area where our surgeons have been very kind to us to get our assistants to be involved in managing these patients, and we come and do motivational round as well to get him to press the infusion, the infusate. Every time he gets a bolus of medication, he would wait for the block to kick in, and he would start his exercise. So in terms of risk, you have listened to what Professor Kim has mentioned earlier. There are other stuff that may be associated with cost as well. When you have patients with reduced length of stay, prevention of hospital readmission, additional necessary treatment to treat complications of opioid, for example, these are benefits that may not be apparent or tangible in our eyes, but in the long run, it would benefit the hospital administrator and save costs as well. And in terms of complications, last complications depends on which papers you quoted. It ranged from 0.08 to 0.28 per 1,000 a single shot, but they are very minimal to no cases of catheter-related peripheral nerve block associated with LAST. This was, however, a paper by Girish Joshi in 2016. In terms of peripheral nerve injury, again, he quoted a range of incidence of 0.5 to 3.5%. It's higher in interscalene block. And another review quoted an incidence which varies to duration. And you could always find this to benefit your explanation of risk and benefit to your patient. And there's also site-specific risk involved, as in fall injury, hemidiaphragmatic paralysis, and Onnes syndrome in interscalene block and in supraclavicular nerve block, where you would also have to be watchful for pneumothorax and possibility of Onnes syndrome. And how to manage some other complications related to infection, for example. This one particular study is on 700 plus cases where they try to culture the catheter tip, and what they found was that there are colony of organism grow from the catheter tip, but only one patient actually developed catheter-related infection, and none of the patient developed a sepsis symptoms. And from the result of those who developed colony of bacteria from the catheter tip. What was found was that from the logistic regression, if you want to keep catheter for longer than 2 days, if your patient is diabetic, if they were on prior antibiotic therapy, this is where you would want to be extra watchful, extra careful on your daily monitoring of the catheter site, and be extra watchful on how you secure the catheter and remove the catheter if you have any doubt of any infection. There are also reason why we get dislodgement or displacement of catheter when, particularly when the line of catheter engagement into the nerve area is non-linear. If you take a longer route or you keep going right, left, up and down, you will find that the catheter buckles and it gets easily dislodged from the area. There are also incidents of noted catheter leakage, as mentioned by Professor Kim, catheter disconnection. I find with current clamp filter tip, you probably have to be watchful on extra tape around the clamp so that it is not easily dislodged. And there's also a possibility, very low risk of catheter perforation, kinking, shearing during performance of catheter nerve block. There's also cases of reverse Horner syndrome secondary to catheter irritation of cervical sympathetics. And the organizational staff and culture, there's one of these or one of the challenge that in the workplace that I think we need to be aware of. This is my regional anesthesia zone. I think 4 years back, very basic stuff, monitoring, very small cupboard there, all the necessary drugs, rescue drugs. I think there's a role in having more people engaged into doing block. If you have a parallel room, this has been discussed in publications of the need for establishment of a parallel place to deliver block. If you have parallel processing system in your OT, you would get more people benefit from block at the same time while waiting for surgery to be commenced. And the block can also be performed pre and post surgery. And this is the area of block now where we get it. We get the area a bit more bigger, more ultrasound, more monitors, and more people are willing and happy to join the area for blocks. In terms of operative funding and cost, I can easily, I've done my calculation. If you do a single shot and followed by PCA, oxycodone, IV Dynastat for 2 days, I calculated the cost of about ringgit Malaysia 330. But if you do a continuous catheter with Celebrex and PCM post-operatively, the cost is about 310 ringgit. You know, if you want to know how I calculated this, please PM me. So the funding and cost related to performance of catheter nerve block is actually what you call comparable to other ways of performing other ways of modalities of pain control. And from we have listened to Dr. Shah, who's mentioned on how to buy in surgical support. I think having gone through evidence and sharing them with surgeon is important. Sharing the procedure-specific pain management strategies to surgeon is something that would improve the management of pain in your areas, and they are all available on the internet. And having people around you who's willing to be trained, willing to mentor your training processes are also important. We have MySigra is currently hosting our own channel, special interest group in regional anesthesia. You can go through and browse through. There are a lot of recorded presentation and videos on performance of blocks and catheter. And training and mentoring is important to know what are the indications of catheter, peripheral nerve block, the approach, pre-planning, pre-counseling, and the insertion technique, the guidance on getting it done right. Whether the approach that you should opt for parallel approach or perpendicular approach, the length of catheter inside the nerve bundle, the nerve plexus, Professor Kim have mentioned this earlier on, how to fix the catheter. There are many ways, find ways that is familiar to you and good to practice in your institution is what important, and delivery techniques as well as ambulatory services that could be formulated in the long run. We have many different delivery technique. Important is to know what is your familiar in your system, in your acute pain service. Have intermittent manual boluses, continuous infusion, patient control, intermittent boluses, patient control, regional anesthesia, program intermittent RA boluses, or combination of both. And I end my slide with this quote: you're either part of the solution or you're part of the problem. If you want to really drive your team into getting more continuous peripheral or catheter peripheral nerve block advocated and implemented in your place, I think these challenges are what you probably need to look at, and we will definitely tackle the interests of the surgeon and the benefits of your patient in the long run. So I think I'll stop here. First question is, anyone practicing tunneling technique for catheter fixation? Professor Kim, what do you think of tunneling technique to secure catheter?
Regarding the post-operative period, in our institution, we usually do not the tunneling procedure because it is effective. But in practice, they usually the catheter over time. Then sometimes they use the tunneling practice in the pain practice management. But acute pain management for immediate post-operative period, we don't use the tunneling technique.
Thank you. Dr. Shah, do you use tunneling?
I don't tunnel anymore. I used to many years ago, but I think so far in my experience, the best way to secure it for the 48, 72 hours is actually tissue glue. Tissue glue would be my advice.
I still use tunnel for long-term catheter placement. I think I have longest I have a cap for a patient is about a month for infusion of medication before patient passed on at home. But I think this is institutional related. And I think, Professor Kim, from the way you presented earlier on, there are very minimal cases of displacement or dislodgement of catheter with the way you fix the catheter, right? Am I right?
Mm-hmm.
Yep. So we go on to the next question. What is the general practice of using catheters in Korea? In Malaysia, our general usage of post-op catheters in general very low, less than 10% in most institutions. This is from Dr. Azrin, who is our convener of Malaysian Special Interest Group in Anesthesia. Professor Kim?
Yes, I think that in Korea, it's a similar situation to the Malaysia. I think that that maybe depend on the institution, but I think that generally the post-operative catheter insertion is, I think less than 10% in Korea also. There are many reasons. So I think that the time pressure. So a lot of cases. So many centers don't have the block room for the in-place catheter, and there is some infection problem, and the surgeon don't like sometimes. And that currently we have a lot of drugs, so multimodal anesthesia, and then just a single shot is enough for overcome the very acute phase. And then we use the other modality for the rest of the post-operative period. So there are many reasons, but so I think that it's a similar situation in Malaysia. I think that less than 10%. Yeah.
Thank you, Prof. Kim. Another question for you. What is the dose of LA you use for femoral or adductor canal continuous infusion? Do you use any adjuncts?
Actually, we don't use any adjuvant for the prolongation of the local anesthetic, because if we use the continuously administered, we use the continuous peripheral nerve catheter. We don't use adjuvant. We use just 0.2% ropivacaine for adductor canal block, and we use the 3 milliliter bolus and then 3 milliliter per hour continuously, and the lava time is 30 minutes. is our regimen, but I think that there is a lot of regimen for the continuous the administration. Yeah.
And I assume this is for total knee arthroplasty surgery. Is that right? Okay.
Yeah.
How long do you
Yeah.
keep your catheter for?
Less than 2 days,
Right.
3 days, but usually 2 days because of the infection problem, something like that.
Yep. Next question also from Dr. Azrin. What about infusion modes? You have explained on fixed rate, your patient control, regional anesthesia. You have answered this in your answer just now. What would be the next question is what would be the approach to determine what modes to use and how to decide on infusion regimes? Professor Kim. So approach to
So yeah, actually we use the fixed regimen, but currently we think about the automated intermittent bolus for adductor canal block, because there are some reports the favor of the automated intermittent bolus is better than continuous infusion. So we currently consider we have to change the mode or not. So we considering about that.
Yep. Dr. Shah, any input, Dr. Shah?
I'm only using continuous infusion, so not much experience.
Yeah. In my place, I would use infusion only on the first day or no infusion at all, and I would use only patient patient control boluses to cover. This is especially for those patients who have been through surgery a lot and they come in for contracture release or for rehabilitation or getting their range of movement improved. And they would need to be exercised to do exercise the moment they get onto the ward after surgery itself. So the next question is, Professor Kim, hello everyone, would catheter dislocation be lesser if the catheter is sandwiched in between muscles? What do you think, Professor Kim?
I think so, but I have no experience about that. But as I told you before, if there is some longer insertion length, that means that you can sandwich between the muscle. You can tunneling the needle like that. Then in that situation, you have I think you have more safety margin. Even patient move it, so it's possibly yes. But when you're doing that, patient feel pain a little bit, so you should infiltrate local anesthetic when the patient have feel the pain during the procedure.
I think they have pain because we are moving in between fascia, right? If we want to go in between epimysium of muscle, this is where the nerve is normally running, and you have to go through this area, which is especially painful rather than going into or through the muscle. But I think it makes sense to avoid muscle that is that gets thickened and that gets stretched every time you do contraction, flexion, and extension. And I've also some experience doing it not parallel and not perpendicular, but rather oblique, so that I will try to get the catheter longer, and they will be obliquely in relation to the muscle, rather than parallel. They will be obliquely in the canal space or adductor canal space, or avoiding where the areas of muscle contraction is normally getting the muscle, the catheter buckled or dislocated. Next question is, any comparison between a catheter peripheral nerve block versus intra-articular block by Q pump in knee replacement surgery? Professor Kim?
Actually, I have no experience with the Q pump, but I don't know the answer, which one is better. But I think that the surgeon administer the intra-articular injection of local anesthetic after surgery. So I just only that kind of block cannot fully cover the whole pain of the total knee arthroplasty. So I prefer continuous peripheral block.
Yeah.
Maybe I just want to add, I've got some, not so much the for the knee replacement, but I think the pre-peritoneal catheters compared to the abdominal wall blocks as well as the central neuraxial, I think it's, I've seen in my previous hospital in Singapore, I've seen it work, and my current surgeon who does it here at the moment doesn't seem to work. I think there's an art to it. So because technically, if you look at the data, I think there's not many studies around, but those the studies that are published seems to be quite good in terms of efficacy. But in my current hospital, for the pre-peritoneal laparotomy surgeries, I still feel that our blocks are much better than their pre-peritoneal catheters with the on-Q pump.
Yep. And there are no other questions from the chat box. You've mentioned, Professor Kim, earlier on that you do you rather use normal saline or D5% to open up the space? Do you find it, does it matter you use D5 or normal saline if you use a stimulating catheter, or it really you have to strictly use D5?
Yeah, we usually use a normal saline rather than D5. So because I'm not sure that effect of the infection or something like that, but we prefer normal saline for the opening potential space. And actually, we don't use the catheter stimulation, and so just we use when you single shot or just a knob stimulator use. So we just use a normal saline for the opening the potential space.
Thank you. I think we have overrun by about 10 minutes. It's been a fruitful session. I myself would like to thank Professor Kim and Dr. Shahridan for a very good sharing session, I would say. And I would also like to thank Vygon for their support in providing avenue for sharing and academic sharing, and at the same time benefiting from their products. So over to you, Mr. Tang.
Yep. Thank you very much, Dr. Afifi and Professor Kim and Dr. Shah, and as well as participants. I think it's one of the great sessions that we had today, and knowledge sharing, and I'm sure that we will be organizing more events with your help to facilitate and exchange cross-country education program like this. The video of recording will be shared to all the participants, and you will be receiving directly to your emails. And without further ado, once again, take care and stay safe, and see you all soon.
Thank you. Bye-bye.
Thank you.
Thank you. Bye.
Thank you. Bye.